Thaler here with Biomed GPS. Today I'm talking with KrishnanChakravarthy, MD, PhD. Dr. Chakravarthy is an anesthesiologist and pain specialist at Ucsd here in San Diego. He has a PhD in virology and is also the chairman of the American Society of Pain and Neuroscience's recently formed task force on COVID-19. Dr. Chakravarthy, thank you for talking with me today.
Thank you, Anne, for having me today. I'm really looking forward to talking to you about the current state of COVID-19.
I realize the situation with COVID-19 is changing on a daily basis. But from your perspective, where are we right now in terms of this pandemic?
It's interesting. I recently came across a panel that was recently put out by UCSF, and one of the statistics that they had mentioned was in the absence of any intervention, they predicted about 50 to 70% of the U.S. population would have some form of infection with COVID-19, and really the concept of herd immunity, which is this idea that eventually if enough folks within a population get the infection, they build a natural immunity to that strain. Now, we are probably at a critical crossroads in terms of the decisions that we make as a nation, as a society, as individuals, as family members, where we are, in my mind, I see this pandemic really splitting in two separate camps. The one camp, which still believe that aggressive social distancing can flatten the curve in terms of the peak incidences of cases and therefore limitation of number of resources and us moving in the direction of the model that was quite well done in China, to the other part where there is definitely a sense on, is this crisis really overblown in terms of the magnitude and the decisions that we're making that are impacting the economics of daily practices, small businesses, when are we beyond a point of making an impact where we are moving towards what I had suggested, where maybe this will become an epidemic in the sense that it will transition to a seasonal strain of virus where we almost have to look at it as another strain that we're prepping for in 3 to 5 years with vaccinations every year, just like we do with a seasonal flu infection. So that tipping point, I think, has created a lot of critical questions, both culturally, I think, from a perspective of clinicians to patient relationships, our own dynamics in our families, our relationships with loved ones. What are the expectations of really understanding and introspecting on how does an individual decision impact a larger public health perspective? And with that, I think there's just so much that we can learn from this. I mean, I think history has taught us a lot, but I really believe that the decisions we make in the next month to 2 months is going to have a tremendous impact on how humanity faces one of the largest challenges we have come across in a long time.
There's a lot of discussion about flattening the curve. If the movement toward herd immunity was really the predominant one, wouldn't that, in a sense, overwhelm our healthcare resources?
It depends. I mean, I think that's a really a fair question. So ultimately, what one can argue is and this is where I think it's very important to make sure that people understand this is not just another seasonal flu variant. And the argument that the denominator that you're seeing isn't really a reflection of the numbers on morbidity and mortality. So, for example, if you go to the Johns Hopkins site, I mean, this is obviously very well known around the country. People are looking at that site. You see a growing number of cases, and you see the mortality number, and you see a recovered number. Now, that mortality number, a percentage of that will continue to drop as you continue to test more and more people. The question then becomes, as more and more people get tested, how do you effectively streamline the system and your resources to algorithmically approach those patients? Is everybody that tests positive requiring the same level of intervention that maybe somebody who is less symptomatic should even be getting a test or just being under self-quarantine? Now, why the flattening the curve, and I do really strongly believe in this, is that it comes down to resource allocation. I agree with you, Anne, because there is limits to what any health system, whether it's in the number of intensive care unit staff, whether it's in the number of beds, it's in the number of ventilators that is in any system. And beyond that, if you have an excess number of cases, then this is the classic model where in Italy, they're struggling to understand resource allocation in terms of mitigating some portion of that morbidity. Whether that morbidity eventually starts to uptick the mortality rate may or may not is completely contingent on how much of those resources you have consumed. So part of that is understanding, I think, to some extent, why there's so much public health emphasis on aggressive, strict quarantine, because there's no half measures that really work for this to work. And we know this because we've seen this in China. We've seen how much of an aggressive government intervention really plays into quarantining at the point where anyone who tests positive is almost isolated from anybody for 2 weeks, because clearly they automatically can become some form of an asymptomatic or mildly symptomatic carrier that continues to spread. So unless you're taking all or none effort, it is very difficult epidemiologically to justify saying that we're going to truly be flattening the curve. That's not to say that any amount of measures shouldn't be taken, because as long as, the classic example is treat yourself as if you've got the infection, because that would be the strictest quarantine you would apply. But I do feel that there is a part of this that is the balance between, if the curve doesn't rise as fast, then the amount of resources that you do have, you have the time to build those resources, or they're basically used in a flatter rate over time. There's without a doubt that I think there's incredible value to social distancing and that concept, because it's not just the peak of the curve, it's also the rate of rise, right? Because that's a complete, from a public health perspective, that's an issue of resource allocation, how you use the resources in terms of the number of patients that actually need it.
There's been a lot of talk about testing and that, early testing, the whole public health detective and capturing those patients. I think we're kind of beyond that, right, at this point, because we don't know how much it's out there in the population. And some of the cities in the United States, I heard recently, are not testing anymore. What are your thoughts on that?
I think this is similar to the model that, as a physician, you hear a classic example. People say you don't order a test unless you know what to do with it. It's an interesting paradigm, right? Meaning that a test is only as useful if it gives you something of a meaningful outcome from a clinical perspective. Let's take an example. Pediatric patients that typically get really bad influenza infection. There isn't really any treatment for viral infections. It's not like a bacterial infection where you are coming in symptomatic with a high fever that you could even put somebody on an empiric antibiotic regimen. So with viral infections, they always say it's kindly defined as supportive care, fluids, hydration, you help reduce the fever, and you try to do symptom management. So where testing in terms of flu infection for pediatric patients makes sense is if you catch them early enough and they're positive, a certain demographic age group that are really young may benefit from Tamiflu intervention early, because it may reduce the height of that symptom and therefore the kind of the comorbidities or secondary infection risks that can happen with flu. So likewise with COVID-19, the question then becomes, does testing change your outcome and trajectory of your management of these patients? So one classic, this is what we're observing, and this is what the data is showing. The most common effect of getting infected with the COVID-19 virus is that you have a very robust immune response. And that robust immune response translates eventually to some form of lung injury. We define that goes to what's called ARDS, acute respiratory distress syndrome, right, which you need a ventilator. Or it translates into having a secondary infection with pneumonia, where you're again managing it through antibiotics if it's warranted, and or some form of ventilator support. In nowhere in this does it really change knowing whether I had an infection with COVID-19 or not. To me, that part of it, you're managing them symptomatically again without an official treatment. Now, if we get into the phase where I see this in, let's say, 6 months to 12 months where you have a treatment, then it makes sense that the testing can be of benefit because it helps you allocate that treatment appropriately. we are past the point, I think, where testing can be an effective way to quarantine. You hear classic examples where there's a positive subject or patient or individual who gets on an airplane and knows that he's positive, he's asymptomatic, or gets off the plane. I mean, this is a classic example with the JetBlue that we recently read where the individual came off the plane and then reported that he was positive. I mean, that tells to me that there's a certain level of critical inflection point that we've passed, that probably using testing to strictly quarantine is not going to be as effective, and it may be a wasteful use of resources.
I understand that if your testing doesn't help you treat the patient any better, that makes sense. But does that mean that we should treat everyone as if they have it?
I think at this stage where we are, you risk the balance of where do you have limited resources to. If you test and you're consuming personal protective equipment, you're consuming equipment for less significant cases, there isn't a clear answer to this. Should we assume that everybody has it, therefore the best chance to flatten the curve is take an aggressive lockdown for the entire country for 2 to 3 weeks and see if we can blunt this upward exponential trajectory? In the ideal case, yes. I mean, this is the model that is been proven in China. They literally cordoned off that entire area and had anybody that, I've anecdotally heard that if you tested positive, you'd be pulled out of your house, put into quarantine or a shelter site where you would not be able to interact with the, let's say, population that isn't necessarily sick. But I just worry that as we continue to test and the numbers continue to go up, if you're not mindful of the fact that there's a resource limitation and it's not keeping up with that, then you could be in a position where maybe you're not using the resources appropriately for the patients that actually need it. And I think that's the challenge that we're going to run into the next 2 to 3 months.
I understand you studied the 1918 flu pandemic, the Spanish flu, as part of your PhD dissertation. What can we learn from history? How is the 2020 pandemic different?
It's a great question. So I'm obviously very passionate about this topic because I had done a 3-year thesis of which I actually ended up spending a year at the CDC working with the 1918 strain. So if you've ever seen any of the movies like Contagion, et cetera, I always joke with my family that that was me at some point in my life doing similar research. Look, the 1918 strain is a fascinating case in both public health as well as what it taught us. So what we know is that when they had, after the death tolls took large numbers of worldwide, around 40 to 50 million people was the fatality rate from the 1918 strain, they eventually dug up the permafrost where some of the old patients were, and they looked at the lungs of these infected patients. So interestingly, influenza and a lot of viruses, the primary cause of mortality isn't necessarily the virus. And so this is what a lot of people confuse them, is that, is this virus highly virulent, therefore it is the primary cause of mortality. Unlike you look at the avian flu where you have this phenomenon called a cytokine storm, with viruses, you're always balancing, if it's a highly lethal virus, sometimes it can be less of a public health issue because it doesn't transmit as easy. So in the 1918 strain, the primary cause of mortality was really secondary pneumonia. At that time, antibiotics by and far hadn't really been developed and sophisticated to the point that we had access to them like we did with the Hong Kong flu that subsequently happened, and then even come fast forward to the bird flu in 2009. But essentially, with the 1918 strain, the case study that was most interesting in that experience was that fact is that at that time, they didn't have the public health measures or the way to track that we have today. So even though people were infected, you could see literally even within the United States, states that used aggressive social isolation measures and states that didn't had a totally different outcome in terms of mortality rate. And so the biggest advent of 1918 really spreading was it was in the military barracks with close proximity. The virus would literally jump from one patient to the next, and they would all get succumbed to secondary pneumonia at that time frame. So my thesis work was really focusing on the conceptual design for treatment as a molecular immunologists, we were looking at immune mechanisms. But what is really fascinating in the 1918 story is it taught the world an important public health lesson. At the end of the day, the things that can curb the mortality numbers are being extremely disciplined to understanding how a disease process goes, in this case with COVID-19. Back then it was 1918. But those social measures or isolation measures are there basically to curb that peak. And that was a hard lesson for the world. 40 to 50 million deaths worldwide is a telling story of what can happen if a system gets overwhelmed in terms of resources, as well as not understanding population decisions that impact the outcome of the disease process.
At that time, if people were dying from pneumonia, did they not have antibiotics back then, or was it a viral pneumonia? Is that what you're saying?
It was actually a bacterial pneumonia. It was they didn't actually have antibiotics to the level that we have today. So the most common secondary infection was strep pneumo. What would happen is that you would create lung injury, and the lung injury would open up footholds for strep to basically grow from. So you hear this a lot, right? What happens, and if you look at and this is kind of consistent with the whole COVID-19 response, immune response. So the more novel the strain, in the first 4 days, your body has a very heightened type 1 interferon response or immune response. So the height of that immediate response predisposes at day 7 or 8 to secondary infection. So how does that make sense? Well, if you have a very robust response, naturally you create more damage. It's not like one can actually see, the body can temper what is and what isn't an appropriate amount of response just to clear the infection. It's like you're putting in a grenade and you're hoping that you clear as much of the virus as possible. But the byproduct is that there are a lot of commensal organisms that the immune system is fighting. So in that process of suppressing that excess response initially, the body then becomes susceptible to secondary infections like strep. The whole idea now is that if you look at a lot of the pharmaceutical companies that are targeting specific drugs for COVID-19, you see they're targeting interleukin-6, or they're targeting things that are tempering that initial response to a novel strain of virus in the hope that you don't need as robust a response, therefore you don't get as much secondary injury that may predispose you to ARDS or a pneumonia type picture after 7 to 9 days.
So in those treatments, is it most beneficial, similar to Tamiflu, where it has to be given within a certain time frame to capture?
Absolutely. So immune adjuvants like that need to really be captured in the first probably 6 to 8 days. And it's hard because not everybody will tell you, not everybody knows when they are actually carriers, right? And especially with COVID-19, you have a 24 to 48 hour asymptomatic incubation period also. So you could potentially have a situation where for 24 to 48 hours, you could be starting to rev up that type 1 interferon response that you're not even aware of till you start to give the classic examples: myalgia, I have systemic body pain, I have fever. All of these things are really a byproduct of the body's response to the virus infection. If we can get those patients early, the theory that we are trying to develop, and we're also working on at Ucsd as a pharmaceutical adjunct, is if we can down temper that immediate response, maybe there aren't going to be as many patients sick that are going to end up on ventilators and or have refractory ARDS at that point requiring intubation and ICU management.
That almost sounds counter to what the trend is toward not testing, though, doesn't it? And then you hear stories of anecdotal Twitter, these kind of things, where people will say, I went in and they couldn't do anything for me, and they told me to come back when I had trouble breathing. I'm like, do we wait till they have respiratory distress before we treat these patients? You understand what I'm asking?
This is the thing I was getting at earlier, right? And so if you know that test changes the course of your management, in this case, if I knew that somebody is positive for COVID-19 and I can give them some form of drug or some form of intervention, I'm all for it. But if you test and just knowing that you're diagnosed with COVID-19 and it doesn't change the fact that if truly for most viral infections, we don't have the same thing we have with bacteria where you have an antibiotic to treat. We're still in supportive symptomatic care. So at the end of the day, if you are testing and just knowing that you are positive only dictates, in the absence of you having no respiratory issues, simply quarantine, which becomes, again, a public health measure. It doesn't necessarily change from a clinical perspective what I would do. However, that will shift because in, let's say, 6 to 9 months, you're seeing a lot more clinical trial drugs being tested. And once those drugs get approved and they're validated in good, appropriate clinical trials. So you heard Dr. Fauci talk about chloroquine, the anti-malarial. So there's different schools of thought. You read some of the work that was done in the front lines in China, and a lot of physicians were using that. The hard part about drug validation, as well as the good part about drug validation, is we spend on today, the average cost for a drug to market is about $1 billion going through clinical trials, rigorous clinical trials, phase 1, phase 2, phase 3. So why is the cost so high? Because they look at all of these things. Is it the right criteria for use on a patient? Is this the right demographic for us to use it with COVID-19? What's the upper limit of dosing? What's the lower limit of dosing? When does side effect benefit versus the benefit of the drug? So I think you have to be mindful that there's a lot of testing that needs to be done to truly validate any therapy in this population of patients. But I think that's where you see the flip for where testing would actually be very relevant.
What about UCSD? What kind of research are you working on at UCSD in this area?
We have a startup that we launched about 2 years ago. Looking, interestingly, there was a compound called erythrorin that had gone into phase 3 clinical trials for sepsis that didn't have any actual benefit at that time because, in my hypothesis, the immune system had gone so far that there wasn't actually any benefit to putting an immunomodulator, especially when you're in multi-organ dysfunction. But interestingly, there was growing data on the role that toll-like receptor 4, which are primarily found on a lot of our microglial cells that drive the immune response, and are also predominantly the factor that drives gram-negative bacterial secondary responses. They had found that this toll-like receptor 4 actually, if targeted, can have a huge reversal in chronic pain. So great, how does this connect? Well, in 2013, there was a group out in the University of Maryland that found that if you took seasonal and pandemic flu and you gave TLR4 inhibitors in the first 6 days, the earlier you gave it, you could reduce a lethal dose of influenza infection to almost under 5%, meaning that it played into the hypothesis that I've been telling you about, which is if you can target the immune response early enough, not only did it affect the mortality rates, it reduced the lung injury significantly and actually even helped the animals do increased clearance of the actual infection. So we are partnering up right now with VA San Diego Healthcare to initiate a phase 2 clinical trial because we would have the phase 1 data. We're probably about a month or two shy of patient enrollment, but I think there's going to be a tremendous push to try to get these patients these immunomodulatory interventions early to prevent the comorbidity on needing ARDS or some type of ventilator.
So realistically, how far away are we from a potential treatment?
Oh, probably at least 6 months to a year. That's conservative. And then you hear this a lot from the FDA. Just put it into perspective. You need, right now they have what is called the compassionate use or fast track cases. So you apply for a new drug, you get it approved, but then you're hoping you have a PK/PD data. So phase 1 is really understanding kinetics and dynamics of the drug to enable a efficacy trial, but it's a long process. So ultimately, the question then comes is how much do you want to reduce the stringency of this in the context of where we are? I suspect that at this stage, given what I've understood, we're probably moving into significant communal transmission, which is to that point of herd immunity. We're going to get the symptomatic people. We're hoping that these drugs get approved fast enough to help reduce that overload on the health system, but it remains to be seen.
Let's shift gears a little bit and talk about all this in the context of pain management. How has this pandemic been affecting pain management practices?
This is a tremendously complicated question, and I'll tell you why. Pain physicians kind of are in all different practice environments. There are folks that are private practice, solo practitioners that literally live paycheck to paycheck to pay their staff, to pay salaries, etc., all the way to academic practices like UCSD, Mayo Clinic, Johns Hopkins, where you're part of a bigger system. The difficulty comes in that this is the first time as pain physicians we are asked a very fundamental philosophical question. Is pain necessarily truly an elective thing, or is it really an urgent issue? And where you fit in that spectrum determines how aggressive or not aggressive your opinion will be about social distancing and should I be or not be canceling elective cases like doing an epidural, and or should I be figuring out ways to get access to certain pain meds inclusive of opiates. So I think that it is a very, very challenging time for pain clinicians because there is a tremendous pressure for a lot of clinicians that are living by the paycheck to continue to keep their practices open, to continue seeing their patients. And I think if you asked purely from a perspective of, I want to apply a hard rule, that would be, in some sense, a difficult rule to follow. Because at the end of the day, there is a commercial need as well as from a perspective of patient care, one would say that's not necessarily elective in my mind, because if I don't treat this patient's pain, then he's going to end up in the ED and tax the resources, versus somebody who may have a different perspective, which is, why can't somebody wait 2 to 3 weeks to get an epidural? Is it really that urgent? And should we really be exposing them to an environment where you're trying to really aggressively do social isolation? So I think it is a very, very challenging time for pain providers, not just from a perspective of who to triage, but how do you take all the data that's coming out? Is giving somebody steroids increasing or decreasing their risk for infection? Should we be looking at NSAIDs versus Tylenol for pain control, depending on different data that's coming out nationally that may or may not actually be consistent? Some say it's good, some say it's bad with regards to non-steroidals like ibuprofen. All of these things are constantly shifting, and I think we are in a very, very critical time that's causing a lot of anxiety for a lot of pain providers.
Well, certainly hospitals, the College of Surgeons came out, and a lot of hospitals are canceling all elective procedures. I work at Pomerado, and they are not doing anything elective. And some surgery centers, I think, are following suit. I would assume that unless they can do some of these cases in their office or private practice, which I don't think they can do spinal cord stimulators, from what I understand. In terms of the procedure number, don't you think that will affect them to a certain degree?
Oh, 100%. There are practices now that have completely closed shop. So they are moving their clinical visits to telemedicine, and they're basically shutting down any elective procedures, including epidurals, facet injections, you name it, SI joint injections, stim trials, stim perms. And the only other thing they would deem as urgent are potentially intrathecal pumps that are infected, pump refills where, patients can go into withdrawal. And even now, just given where you hear a lot of the DEA relaxing some of their rules with potentially using telemedicine with some kind of video conferencing to be able to prescribe opiates, I think the system is trying to make as much of this fall in the line of being elective. The question then comes is, and the challenge that I at first, if you had asked me, should we have adopted this with no questions asked on duration of time, that this is what we were going to do maybe a month or two ago when we're trying to really do the aggressive social distancing isolation to prevent this rise, I would have said it makes sense 2 to 3 weeks, 4 weeks. The difficulty now that is challenging is, how do you provide framework for clinicians when you have to be mindful that, can you really be without doing procedures for a month? Is this 2 months? We already know that this is not going to go away. That's not how infectious disease works. This is possibly a long haul where it is going to change the fabric of how we do things. So we have to adapt. And with that adapting to the time comes a lot of critical questions. Pain as a field cannot survive without the interventions. That has been the transition and evolution of our therapy to almost similar to where interventional cardiology was with coronary artery bypass and CT surgery. Why I bring that point up is that we are doing all types of therapies that require time in the operating room, whether it's placing spacers, whether it's minimally invasive decompression. All of these things require clinical time, require clinical visits, and require operating room time in addition to the less invasive interventions. So I don't think that it's a sustainable model to assume that we can continue doing this for months on end, and the expectation that a private practice clinician that is in pain could survive or keep his business open. So it is a very, very challenging time, because I think the question then comes is how long can we continue to do social isolation and not provide care to these patients under that context without really looking at what the implications of that would be.
How are physicians adapting their practices?
There are folks that are continuing to work. There are folks that are seeing patients actively, and they are using techniques like screening, whether it's temperature, symptomatic, are they coughing, not coughing, travel history, maybe looking at individual cases of age limits, maybe 68 plus or 65 plus. If there's a higher mortality, you might be more hesitant to consider them for a procedure, and really looking at each individual case on a case-by-case basis. Then there are clinicians that are taking a way more aggressive approach, which is saying, I'm canceling everything and just doing telemedicine. So you're getting a spectrum of all different approaches to this. And this is where I think from a society level, we need to provide some guidance, but be mindful that we don't want to come off as prescriptive, because at the end of the day, we can't understand an individual circumstance. If you can't have a paycheck and you can't pay for your next meal versus the larger public health measure, can we find a balance between the two? And that is going to be something we're going to have to navigate the next 1 month to 2 months in terms of educating our members in the global pain community, physician community at large.
So in terms of procedures, what pain procedures do you think will be affected most?
I mean, at this point, everything, to be honest with you, because if you look at what clearly the stimulation industry is extremely worried, because you're going to see a huge dip in Q1, Q2 usage, because we are still treating everything that goes in the operating room as elective unless it's an urgent need, which this would fall under. And then the transition question then comes to if you could at least implement telemedicine at the level of the clinic visit, can we potentially consider an epidural injection for radicular pain and or some of the other less invasive interventions as something that's not elective, or some way to take care of these patients if they don't have another option other than going to the ED seeking for opiates. So I think it's affected the entire spectrum. There isn't one procedure outside of clinical visits directly interacting with the patient that we are trying to figure out an algorithm for when is it appropriate or not appropriate, what is elective versus not elective in terms of any of the interventions that we're currently doing.
Sometimes I know when you guys do trials or a patient is a candidate for a spinal cord stimulator, sometimes they end up having to decide and they can get lost in the system given that there will be all these potential delays and postponing these cases. What do you think will happen to those patients? You think they'll get lost in the system? You think they'll get rescheduled and we'll see a big influx in Q3, Q4? What are your thoughts on that?
I always feel that you shouldn't be committing somebody to a trial unless you can get them through to the implant and complete it. So I think physicians that are doing the trials and referring them to surgeons that are going to do the implant have to be very, very disciplined and mindful that, you're putting patients in almost in a holding position where if they get a positive trial, there may not be somebody to actually be able to implement and put in the full implant from a spinal cord stimulation perspective. That is a challenge that needs to be addressed as educational dissemination from both the society level as well as the industry. So is it going to come down to are certain ASCs or big health centers going to be open that are going to be allowing a permanent implant to be done? I can tell you anecdotally at UCSD, there isn't anything that would constitute that as being urgent. So it would fall under an elective procedure, which right now, given conservation of resources, given where we are at this inflection point of increasing number of cases, that won't be something we would be able to do. So we're taking the perspective that doing a trial at this point doesn't make sense because you're putting that patient in a situation that they are not going to be able to get the permanent implantation. Now, in 3 to 6 months, Q3, Q4, when we start to re-ask this question, I think we'll have a better landscape of where this situation is. I don't have a magic ball to predict, but I can guarantee that one of two things can happen. Either we continue to see a growth in number of cases and we take an aggressive stance similar to what happened in China and we start to plateau. And once you start to plateau and the folks that are less asymptomatic start to have this kind of herd immunity, things may come back to normal. The volume will start picking up and you'll kind of see everything slowly track back to normal. Or it may be classically what happened with the 1918 strain, and you look at some of the data that is possible is that we may see a second round of infection. Highly probable that in the fall that the virus comes back, and now we're talking about long-term prevention strategies and rolling out of vaccines and, again, the large public health decisions. So I think there's going to be a lot of uncertainty coming up for the next, I would say, at least 3 to 6 months. And I think we're going to have to be extremely nimble in how we moderate that. So a classic example is incorporation of telemedicine. There are a lot of private practices as well as larger practices that are quickly adopting to technology, trying to figure out ways to make their practices still efficient, whether I'm prescribing certain drugs over telemedicine and or triaging patients. At least it's one more thing we could do given the current circumstance of where we are. So I think we'll have to adapt. We'll have to come up with very creative solutions in the climate of a lot of changes rapidly.
How do you think that overall COVID will affect the industry for market for spinal cord stimulation devices? You think in the short term it'll just pretty much dramatically drop and then there'll be a curve that'll slowly come back?
I think that the challenge that industry faces is that right now there is going to be a precipitous drop in the number of cases. There are going to be folks that have an existing stimulator device that will need some amount of management of it if there's an infection, if there is an aspect of failure of therapy. So the first step that I think that we as pain providers need to do is start to, depending on how long this issue continues, which I suspect it will continue because going to the point I made earlier, we need to really start taking some of the CMS guidelines, a lot of the different guidelines that different societies have provided and start to triage and tier each of our therapies in level of how important it is in terms of their pain management. Because pain by and far is, in some say, is like another fifth vital sign. In the 80s and 90s, when people used to think about pain, it was no different than, I'm measuring some other vital sign that is just as important. So if you have one of those vital signs coming down, you would say that's urgent. I think we have to be mindful of that pain for an individual can be extremely life-consuming, life-altering, and can have a significant impact where they can't live their life. So if that's the perspective and philosophy that we take, then we need to start thinking about taking each of our interventions, triaging their level of need, and then coming to some conclusion on how do we get to the point of putting that out and having an agreement across the country and nationally and internationally. Once we have agreement, then we can start to work together to make decisions on more interventionally heavy procedures like STIM. I suspect that it's going to be very tough for industry for the next 2 quarters because the realization I've come to, and this is a fascinating thing that I've understood, a lot of big systems, whether big health systems or even big companies, how much is reliant on day-to-day revenue to operational expenditure. Classic example is the airline industry. They're not sure a lot of them will survive this, which is surprising because you think how many flights go day in and day out. But the point I'm trying to make is that, we have to be mindful that it could change the landscape, especially dependent on what size the companies are. There are a lot of startup companies that are going to have to be very nimble or find ways to keep a very lean process while numbers of sales is going to significantly dip. And we're not quite sure how long that will continue.
How about clinical trials? How is the COVID affecting research in the pain field?
Clinical trials, it's no different. I think their recent FDA guidance is a really good resource for people. As a director of clinical pain research at UCSD, I think we've got about 15 active trials that were ongoing. The question, and I can certainly, the recommendation or at least suggestion that I would have is, I think a lot of investigators will need to work with their institutional review boards and find out for every trial, look at primarily safety of patients first, right? Is intervention necessary or not within the broader context? How significant is this in terms of the patient health and you weighing out risk benefits? Should you now be incorporating screening in the clinical visits that are doing for research? Should you be changing the data collection components? Are some data sets more important or less important? So it's going to completely change the fabric of literally any study that's ongoing, let alone half the time, half of the research centers you can't even walk into. They're all quarantined. Okay? If you can't actually get there to assess the patient, what kind of clinical trial are you going to be able to have? I think that as an institutional review board member, I think we have a lot of work to do. I think there's going to be some challenge of when these trials are starting to come back, should we be prioritizing? But, I'm hopeful that at some point within the next month or two, we have a better understanding of the trajectory of the disease. Therefore, then as a society and as a nation, we're going to make decisions based on that being the new norm, as opposed to at this point really looking as a public health measure and trying to curb what would be the present state of the norm and hoping that we can kind of retain what we have going, as opposed to reestablishing a new base equilibrium and saying, okay, this is where we're at. Therefore, let's adjust things to work at that new baseline.
Tell me about the ASPN COVID-19 task force. Why a task force just for the pain management field? What do you hope to accomplish?
If you ask an interesting statistic, 1/5 of the human population has pain. As a society, when this first came out, there was too many changes that were happening that were being decided by the health centers that each of us were practicing in, as well as just national guidelines that the CDC had put out, CMS was putting out. So we didn't think that at that time it was appropriate. But I think as I've kind of been articulating, there's a lot of challenges that are going to be facing our field. And we have a tremendous importance in terms of patient care that is starting to get more and more recognized, that has a multidisciplinary role, whether it is primary care, neurologists, physiatrists, anesthesiologists. We're all operating as pain medicine specialists. So at the heart of that, the task force is really looking to bring some unity among pain clinicians and how we're approaching the new baseline. And it's a fascinating case study. Maybe about 5 years ago, primary literature and or the means of communication has changed so drastically due to social media. It is the era of social media. Literally anybody has access to anything that's happening in any part of the world. So with that, there's immense responsibility at the society level to help our members, help the global pain community really understand the implications of that data in terms of what's viable, what should be meaningful, and then how do you implement that in your day-to-day practice and life, et cetera. Really, the theme of the task force is that we're hoping to be a resource to clinicians that are struggling with these very important decisions, as simple as who am I willing to accept as a patient, to all the way as if I cancel my clinic and everything for the next 1 to 2 months, how am I going to find the right staff when I get back and I don't have anybody to work because I can't pay the bill to keep the business going? I'm almost building it from scratch. So I think we are looking to really be a resource, mentors. There's some outstanding clinicians on the panel, but really to provide support. This is a very, very difficult time for a lot of people. And it depends on what stage of life you are. But I think nature has shown that there's a part of this that is unpredictable and we are going to have to adapt.
Tell me, I understand you're working on some webinars. What's next in terms of education then?
We are going to start with 3 separate webinars. The first one is going to be looking at just getting an understanding of what is COVID-19, what is this pandemic, understanding the concept of social distancing, and really talking about implementation of telemedicine, implementation of all of the different questions that are coming up with proper screening all the way to practice changes that we would be making. The second part of it, I think, is extremely important, which is looking at how is this going to affect training of current fellows and future residents. We, as UCSD and a lot of the major academic centers, we are responsible for training fellows that now have seen their education piece suddenly curtailed. And some are probably 50% or 60% of the way through, and it's a 1-year fellowship. So now you have a very challenging situation. Are they getting the appropriate amount of training? There's a lot of anxiety in terms of, am I going to be expected to come into the hospital? What if I contract this? How is this going to affect me? What am I looking at? Certain exams are getting canceled for certification. So that's going to really help to address some of those questions and at least start discussing on that. And then the third will be a industry-oriented seminar, really looking at the spinal cord stimulation market and trying to figure out how best to work with industry, how best to help them, as well as the physicians that are interacting with their reps and clinicians, clinical specialists, to really get them to understand the dynamics of the new norm and making sure that we are good partners in that, because physicians can't operate without industry. It is a partnership. And so we need to be mindful to help them along in that process.
Please let me know when those are being held, and I'll make sure to communicate that to our subscribers.
Yeah, absolutely. And we're going to be doing a bunch of white papers that we're going to really start to take some of the information from CMS, FDA, and really kind of tailor it to pain clinicians and really getting them to understand how can they apply some of these guidelines and suggestions to their practice. But at the end of the day, we are empathetic to the entire demographic, and it is a very challenging time, but we are hoping to be stewards in terms of giving some feedback and guidance to them. So I really appreciate this, Anne. I think this was a really fascinating conversation.
Of course, I thought it was really interesting as well. Is there anything else you would like to add?
As you said, we are in a trying time, and so what the message to be conveyed, and you hear this all, we are in it together and we will do it together, and I think that's kind of fitting. This has got to be something that the entire country will have to unite, and we need to find a common ground on making sure that we're moving together in the right direction. So we'll see how things turn out, but I'm optimistic.
Dr. Chakravarthy, thank you so much for your time.
Okay, thank you so much, Anne.